I do think that there could be a spot for this in cardiac arrest because there's a lot of time that we're sitting there and we're doing the epi every 10 minutes. Or if they're going to ECMO, we limit it to, 3 epis. And we have a Lucas, and then we have them on the mechanical ventilator, and then we have like the ultrasound. And so we'll do ultrasound, look at the heart. But there does seem like there's a little bit of time that we could possibly pop one of these in. And then we could actually look at that diastolic blood pressure to try to target an adequate coronary perfusion pressure, whatever that might be. Do you think that this may be an indication for pre-hospital art line placement, or do you think we'd be getting into the weeds if we looked at it too much?
No, I think it's absolutely an indication, especially if that. Um, I think it is definitely an indication in the peri-arrest or cardiac arrest patient. It has, for whatever reason, not been super in vogue in the emergency medicine world. I think as when we over the years as we've gotten more involvement and we've had more critical care EM faculty and people involved, and now more and more so with advanced interventions like ECMO, it's becoming more popular, and I think more people in training are doing it specifically for this procedure. So why? I think the whenever you look at an indication like this, or a procedure like this, you have to be careful, right? Because there's no evidence that specifically an arterial line ever saved anybody's life or improved mortality at 30 days or 6 months or anything like that. But within the context of what we're actually doing, that doesn't always matter, number one. And number two, if it facilitates more precise management or better care in the sense that we're doing things more in line with the evidence base, then yeah, it's probably a good idea. So, for example, if you were to, there's some literature that shows that in cardiac arrest, it actually it limits pulse checks, right? Because if you have an arterial line in there, you don't have to sit around with like one person on the carotid and one person on each radial and two people on the femoral and one person. I think I got it on the femoral. I can't feel anything on the. Oh, maybe that was it on the radial. Oh, hang on, let's wait another 10 seconds. I'm not sure. Maybe we do have a pulse. You can just look at the art line and be like, we totally lost the waveform. We were getting good compressions and good pressure, and we totally lost a waveform, number one. Number two, if we're looking at, and what I should think we should be moving to, is a more nuanced management of these patients, not necessarily having to slam them with a milligram of epinephrine every 3 to 5 minutes. But once we have people who are trained in advanced cardiac arrest management saying, all we need is a map of 45, 50, something like that to get good coronary perfusion pressure. So there's a lot of debate about where those numbers are, but you could titrate
Right.
drips and other medications, even if they were push dose, to just that instead of what we commonly see is, like a map that shoots up and then it drops down. Um, so I think that there's a lot of utility there, especially in some of these patients who are very unstable and have a high likelihood that they're going to re-arrest. It's reasonable to place it at an outside hospital for the other reasons that in transport, these patients are super unstable as well, right? There's very few patients, essentially no patients, with a couple of exceptions, that are too sick to transport, really. And moving those patients can be really challenging because, like you said, you're in flight. It's 2 a.m. You can't really see anything very well. Your end tidal waveform has always been, not great because they're not getting great perfusion because they're profoundly hypotensive and in cardiogenic shock. You're titrating pressors, and then all of a sudden you start to see some ectopy. Is it perfusing? Is it not? Did we lose pulses? Did we not? And if you have that A line, it's super helpful. I also would add that I think it's feasible, especially at an outside hospital, right? Because if you show up and someone went into cardiac arrest and then, like the classic, they're doing fine and they have a pulse, and then you show up and they re-arrest, then you have enough people usually with the sending facility to do all the normal ACLS stuff. But then the flight crew, the critical care transport professionals, can actually do other things like, hey, ask the sending physician, do you want me to place an A line so we can, better manage this and titrate pressors, or so we can shorten our pulse check interval? And they as the sending physician are managing the whole scene. You guys can do those skills. I would, however, be add a note of caution there, which is especially if you're at a program that's doing ECPR or has or is involved with the ECMO team for some of these patients. Talk to them and come up with very careful guidelines and protocols about where and when you do this, because for example, for bifemoral cannulation or certain or ECPR, you do want to make sure that I would try to spare the femoral sites for the cannulation team. If you guys decide to do those, you have to have very carefully or very good training on like ultrasound guided arterial line placement. Because you have to be at the right point in the vessel. You have to be above the bifurcation of the profunda in the common femoral, for example. Otherwise, they'll have to stick them again. You'll have to remove that A line. They'll have to stick
I've
them
seen some
again.
places
So
too with the right radial for PCI. They want you to try to stay away from that. So, like you
yeah,
said, these are conversations that if you implement them, just you need to figure out what your systems around you are using and what they prefer. Have you
exactly.
figured out a good way to figure out the difference between a vein and an artery in cardiac arrest? Is there any little tips or tricks?
So really, really good question. And it can be hard, especially if there's ongoing chest compressions. This is where I think the ultrasound comes in very, very useful. Because when you can actually, the classic like anatomically guided arterial lines are fine if you have a pulse and you know what you're doing and you have a lot of training. If not, and you should always use ultrasound first if it's an option. But if not, especially in cardiac arrest, it's really hard. Basically, what you're looking at is often like two vessels that are pulsatile because you have backflow and forward flow from the chest compressions. That's when you really need to know your anatomy. When you really, really need to know your anatomy and what you're looking at in the groin. Some people say you can look at the size and shape, right? An artery shows up very differently on ultrasound than a vein will. Anatomically, you know that the artery is actually lateral to the vein. The vein is actually closer, is more medial. And once you get used to seeing them, when you're scanning up and down and looking at those structures, it gets a little bit easier because you know what you're looking at. It's also a pretty good reason, or it's also reasonable when you're looking at the radial artery. It is generally a little bit easier to see in comparison to surrounding veins in the art, so that the anatomy is a little bit better at the radial artery and not close to any other big vessels that might look similar. If that makes sense.